Welcome to Conceived, the podcast with me, Dr. Kady. I am your host. On this platform, as you know, we talk all things to do with fertility. Today, though, is slightly different because I have a guest. I have with me Dr. Michael Flynn. But before we go into talking to this specialist, this person who knows the ins and outs of IVF, let's talk around IVF in and of itself. So if you're watching this podcast, it is probable that you are looking into IVF and you have been confused which one is right, which one is giving me the right information, what cost is realistic. The list of your questions are endless. And so today I have got the specialist who has made it his purpose to help women conceive their first or second or multiple children. So without further ado, I am going to bring Dr. Michael Flynn on the stage. Hello, Dr. Flynn. Thank you so much for joining me. So a little bit of an intro. I'm sitting with Dr. Michael Flynn, who is from Queensland Fertility Group here in Queensland, and it's on the Gold Coast quite specifically. And Michael Flynn is a surgeon and a fertility specialist who spent his career figuring out how it all works with IVF. He's worked with standard protocol versus personalized protocols, which we're going to talk about today. He could give us the roadmap. So today we're going to talk about roadmaps, we're going to talk about timescale, we're going to talk about protocols, and we are going to talk about the all not so well-known low-cost IVF procedure, particularly here in Australia. Dr. Flynn, thank you once again. But before we dive in, I want our listeners to hear it from you. So, Dr. Flynn, tell us what you do.
So my name's Michael Flynn. I'm a fertility doctor at the Gold Coast, Australia. We've had a fertility clinic that we've worked for now 25, 26 years. But in all that, I've had the ability over time to go the whole journey with couples and deliver their babies, investigate their fertility, and do the things at the very end, which is some type of fertility management, whether that's IVF or there's a whole lot of other fertility options to get the same outcome, which is the family that couples wish.
That's awesome. And do you find that in your 25 years journey, you're seeing more and more people come to you for fertility treatment?
It's definitely changed. The reasons for doing fertility has definitely changed over time. The percentage of people has changed. The success has changed. The types of protocol has changed. So it's a constantly evolving sphere that we're looking at.
Wonderful, wonderful. Okay, let's dive into it. So a couple decides that they want to go for IVF. At least that's what they think that they need until they come to your office. So walk us through, as though you're talking to a couple who know nothing about IVF. Walk us through what happens from the first encounter into your clinic into coming to that stage where you're ready to guide them through what type of fertility treatment that they need.
So I guess the first thing is actually deciding, is fertility an issue? And now in a lot of areas, like same-sex couples, that it's obviously an issue, but there are couples who come along and they're very anxious and things haven't worked for, 4 to 6 months. And when you go through the processes, it still fits into the normal range. So we do that by, if there's what mostly happens when there's a male partner involved, we'll get the story from the male partner, any past history. We'll look at tests that have been done. We'll look at the story from the female partner, because I always like seeing couples together, because fertility is a together thing. You can't do it on your own.
That's right.
So there's an investigation and work out what reason do we think this couple are not getting pregnant. And once we've got that idea, then we can focus on, well, how do we get around it and how do we get you what you want? And if it's IVF, which in a good percentage it is, then we will start working everything up, do the investigations to get all ready to do IVF.
Okay, so very often couples come to someone like me, for example, as a GP, a family clinician, and they decide they want to go for IVF. And sometimes for some of them, time is of the essence. Like you say, some of them want to have gotten pregnant yesterday. Are there some things that at the level of their family doctor they could do before coming to see you that will help with the timeline, you reckon?
So there's a lot of things that every single couple who wants to get pregnant are thinking about beforehand. For instance, there's something called carrier screening today where we look at cystic fibrosis, and we would offer that to everyone before they start IVF, but that's something that you would offer to most women before they wanted to get pregnant. We like to know how many eggs, and it may be a topic for later, the woman has. And so there's a blood test called AMH, which does make quite a difference to us. If couples are worried, it's easy for the family doctor to organize a sperm test on the male partner. Because if everything is reassured and we've only been going for a few months, possibly it's just a matter of reassuring.
Okay. So basically what you're saying, an encounter with you doesn't automatically lead to an IVF cycle. So not everyone that walks into your door will be signposted to having IVF.
Correct.
Okay.
There's some obvious people that, this is not going to happen without IVF. But there is a whole lot that if we optimize this, if we change this, if we tweak this, can really make a big difference.
And that's a very important notion because, IVF is a fertility hot topic, and there is a perception out there that fertility doctor equals an IVF process. So thank you for clarifying the fact that that's not always the case. So I'm sure you've had this question asked so many times over and over again. A couple comes and says, and you decide, this couple is an IVF candidate couple. How long does it take, Dr. Flynn?
Sure. So that little workup at the start often takes 2, 3, 4 weeks. Once you've got that workup done, my standard play is, and you're the one who says, I'm going to do it this month.
Right.
On there. So initial workup, 2 to 4 weeks. After that, you give us notice just before cycle's ready.
Okay, so just before the cycle is ready, the lady comes to you so we take it that it's medication, and we'll get you to talk to us briefly about the different steps from her starting to the embryo implantation. So how long would you say should a woman take time off work? If she's thinking of taking time off work, is it 2 weeks? Is it 3 weeks? How long?
So mostly very minimally. Now it depends a little bit on the clinic and how the clinic runs things and how that interplays with that woman's work. But in the main scale of things, most women would take off the day of the egg pickup and then a couple of days after that. So for the whole cycle, which we will talk about now, there's very minimal work loss if needed.
Okay. And that's helpful for, the people in this generation. People don't necessarily want to know, for people at work to know that they're going through fertility treatment. So they want to lead a normal life as much as possible. So knowing that it's something that can happen quite quickly is really helpful. Now, I presume that that's for the uncomplicated patient. So that's for the patient who doesn't have lots of endometriosis or who's had issues with pelvic adhesions. Is that right? Does it take longer for that type of patient?
The actual cycle, no. So the cycle is pretty uniform, and it's probably worth going through that just to give a bit of a background.
That would be helpful. Yes,
it's relatively uniform. So normal explanation with IVF is in a normal woman's cycle every month since they were 12. The aim from nature was to get pregnant. So they would have a follicle that got bigger and bigger, and in the middle of the month, that follicle burst open and an egg came out. And that was their chance of getting pregnant every month. And that was one follicle, one egg, and then the same thing happened again next month. Where IVF gets its advantage is all about numbers. So not one follicle, but we would use exactly the same hormones that the body uses to stimulate that one follicle, but we would give that hormone, follicle stimulating hormone, back at a higher dose. So instead of having one follicle per month, there's different aims that different doctors have, but if I use the simple numbers of trying to get 10 to 12 follicles to get 10 to 12 eggs, then I'm increasing my chances 10 to 12 times over 1 month.
That's right.
So if we started right at the start of the cycle, using day 1 as our first day of period, we would probably start injections from day 2 or 3. Those injections are FSH injections. On average, the injections go for approximately 10 days. If I did nothing else, we would lose, because we would ovulate, those 10 to 12 eggs in the middle of the month, ovulation time. So for the second 5 days of the injections, there is 2 injections, One is the FSH to make the follicles get bigger. A second injection to stop ovulation happening.
Okay.
So the follicles get bigger and bigger, but they don't ovulate.
Okay.
In the middle of the month, when you would routinely ovulate, I've just said we don't want ovulation to happen. But in fact, ovulation is the final maturation of the egg. So if we give the ovulation hormone or the ovulation trigger, we know 38 hours later that ovulation will occur.
Okay, yeah.
So 36 to 37 hours later, we go and retrieve eggs when they're at their maximal maturity. That's the egg pickup. So that's the day when we see how many eggs we have. That's the day when we put egg and sperm together. And that's the middle of the month, which you would normally accept as ovulation day. Next day, we find out how many fertilize. If I use 10, because it's a really easy number to play with, on average, 70 to 80% fertilize. So let's say on day 1, we have 7 to 8 day 1 embryos. In the normal body, in a female normal body, when we get pregnant naturally, fertilization happens out in the fallopian tubes, and it slowly finds its way over 5 days into the uterus. And on day 5 in the uterus, the embryo is now multiple cells, and the embryo is hatching because human embryos hatch, and that human embryo implants. So we keep the embryos in the laboratory for 5 days. On day 5, so we've gone from 10 eggs to about 7 to 8 day 1 embryos to, on average, probably 3 to 4 day 5 embryos. In a fresh cycle on day 5, so it's now 19 days since the start of the cycle.
Yes.
On a fresh cycle, we would put one of those embryos in and freeze the others.
Yes.
9 days later, so that was day 19, or even slightly earlier, 8 days later, on day 27-ish, we would do a pregnancy test, and we see whether it's worked this month or not.
Right.
So the cycle fits absolutely within the month cycle of a woman's cycle. And the difficult days, I mean, there's lots of definitions of difficulty, so I'm not in any way putting that down, but the egg pickup day is definitely a challenging day. The embryo transfer day is usually not all that complicated. And then the big difficult time is that time waiting for positive pregnancy or not. That's a cycle.
Yeah. So you've touched on the next question, essentially. So if you had to warn a woman, a couple, of something to expect, so something to prepare for that might affect the cycle, something that they might not necessarily be aware of, to prepare them emotionally and possibly for the woman physically, what would that thing be?
So I think there's one thing, because everyone comes up beforehand and has the same questions. Like, I don't think I can do injections. And the answer straight away is everyone's on Ozempic today. And
yes.
It's exactly the same injection. So I'm absolutely confident you can do the injections. But so the big thing is, well, 60% isn't going to work this month.
Yes.
And that is so difficult to prepare for, because no matter what, and I think the same, I think it should be working as well, but that's where it really gets them emotionally, gets them everything. I've done all this, and this time it hasn't worked.
Yeah.
And trying to explain it's a sort of a cumulative effect is a really difficult thing to do.
Yes. So you say this time it's not going to work, and you say the average age. Can we touch on age a little bit, because that has a significant implication in terms of the success of that cycle?
Age is absolutely important. Age has so many pointers as to if it's going to work or what our success rates are. So the standard success that we're talking about around that type of 40%, we're always talking in our terms of a woman around 35. And even though I don't want to say it out loud, but fertility really, really goes downhill from that time.
Yes.
And no matter what, we can't expect the same success rates over 40 as we do at age 35.
Yes.
And so if I had one take-home message of anything, is don't wait.
That's right. Okay. We'll probably get you back on the show, and because I know you've developed this, it's a calculator of when to freeze, like freezing your eggs and being able to work out the success rate based on your age. And egg freeze in and of itself is becoming a thing. More and more women are deciding to start their families later, and a lot of women do not have the awareness of the fact that they can freeze their eggs. I guess they know about it, but by the time they realize, hey, I need to get this done, they're 37, 38, some of them even 40. And the chance of a successful embryo from that frozen egg has significantly reduced. But that's a whole separate show in and of itself. And so we'll come back and address that. So we're going to switch up a gear now, and we're going to move into talking about personalized matters, personalized protocols, right? So I want to get into a behind the scene of what happens for us doctors, for you most, especially the fertility surgeon. The idea around protocols. So for someone who's never heard of protocols, what does that mean when we doctors use the word protocols when it comes to IVF? And are there different protocols?
So firstly, I believe that if we're putting a woman through what's quite a significant thing emotionally, cost-wise, everything, we should have an evidence base. So I shouldn't be offering things without, I've got all these studies behind me. I know that if I do this, here's your chances of success. Here's the chances of bad things happening, of complications. So there are definite protocols that have, IVF today is a really good scientific basis. I was at the European conference 3 weeks ago. There was 15,000 people, and the things that are being presented and how they're manipulated and how people look into it is really very robust. So the protocols is not just something that come out of a window. So I would think that 90% of women would use a very, very, very similar protocol, because the standard protocol, so the standard way we work out the dose of that follicle stimulating hormone, FSH, the standard blocking of ovulation, the standard triggering works for most women independent of the reasons for their fertility. So it's 10% where we start in trying to optimize their medical things. Example, or a couple of examples, but the classic example is that frustrating woman with what we used to call PCOS, but now we call PMOS. And these women think they're infertile because they've got no eggs, and it's exactly the opposite. Ovaries are really resistant. We've got heaps of eggs, so we're not going to run out of eggs. But oftentimes they don't exactly respond in a dose-response relationship as all the other women do. And oftentimes it's nothing. We're all getting frustrated, and then everything. So it's an all or nothing event. So potentially women who have very few numbers of eggs, and also some very special cases, like we do fertility just pre-cancer, so pre-chemotherapy. There's a lot of individualization of protocols in specific cases, but 90% of couples, it's pretty much the same type of process.
Same type of process. Wonderful. So let's say you who came into your clinic, but this woman you are her final port of call. She's had 4 previous failed IVF cycles. She's been given the reason as being poor implantation, 4 weeks as an example. Does the cycle tweak a little bit for her? Do you personalize it in any way? Is there any special injections that you can give her?
So I think it's important when things haven't worked, whether it's someone else coming to me or it hasn't worked for me, because I'm not immune to things not working, but to go back and so throughout the cycle, we do a number of blood tests to make sure how things are going. And so looking back at all those blood tests, how was the responses? Because there is a few things that we can manipulate with stimulation. There's different ways of optimizing things. What's potentially important though, and I think is a small problem area in our industry, is the use of things that don't have a great evidence base behind it. So if we use that very specific example that you gave of recurrent implantation failure, it is so frustrating and so emotionally devastating that you want to say, I want to help and use things, and a lot of doctors do, but without any evidence that it makes any difference.
Yeah.
And women come in asking for it as well, because I've seen it online. And I think it's very important for us to say, I know where you're going through and I understand what's happening, but I really don't think that thing you're presenting is going to make any difference despite what you've read online.
Superb. Okay. That's you being very open and being very honest. But when she's gone through, that trauma of multiple failures, and she says, I want to try it. What's your approach? Do you try it? Do you not? What's your stance? It's a very difficult question to ask, publicly, but what's your approach in that situation?
My background is evidence-based medicine because I want to give you confidence in what you're doing. There are definitely some times that, and a lot of us do, and I can't say that I don't, that we think theoretically that this is a reason that things don't work. And theoretically, this treatment may make a difference. And in that case, as long as I know I'm absolutely not causing any harm, I'm prepared to discuss it.
Okay.
So if I gave a pretty benign example, like the use of aspirin, and aspirin is a drug that's used in a lot of places in medicine, from heart attacks to for women who are pregnant and who have that terrible thing called preeclampsia. Aspirin makes a really big difference. And theoretically, does aspirin make a difference with pre-implantation failure? Well, possibly, except there's no evidence. And my plan behind that is, if you want to use it and we talk our way through it, I guess I've got no evidence to say that is doing any harm. Whereas there is definitely possible medications that are used and given that have no evidence and can do harm.
Can you give an example of one of those medications? Just so that my viewers are informed, or my listeners are informed. And so when they go to a fertility specialist who's saying, yeah, you can have this, they're informed that this drug could potentially do them harm.
If we think one of the reasons for recurrent implantation failure, that it is very possible that's present, but in quite a low percentage amount, would be that of immune factors. And within immune factors, as doctors, as in family doctors, you would treat immune things in a number of different ways. And one of the ways, for instance, is in asthma and immune things, is giving steroids.
Yes.
Now, steroids in a prolonged presentation is not without risk. It is something that you really should understand the risk. Because there is no great evidence of using steroids to make a difference with recurrent implantation failure. So I think as doctors, it's important, if patients want to use things, for us to talk through so that they are making informed decisions.
Precisely. Okay, that's very helpful. So I'll ask about one more drug, because I've heard great things about this drug, and I want to get your opinion on this and whether you would include it in any of the protocols that you would use. Progesterone. What's the role in progesterone with for patients who go through IVF? Does progesterone play a role? Do you give progesterone to all of the women who have had IVF? Is it safe?
So I was really slack when I talked about standard protocols before, because I talked about FSH injections, I talked about trigger shots. But in truth, I give every single woman who's having an embryo transfer progesterone, because it takes away that variable. Progesterone is normally produced by the follicle that's after it's released the egg. And so progesterone is what sustains the pregnancy early on. So progesterone, there's almost no risk on that. There is really good evidence in things like recurrent miscarriage. In fact, it's the only thing that there is evidence in recurrent miscarriage that giving progesterone makes. So in my protocols, every woman that we put an embryo in, and in fact, every woman we do things like insemination, where we don't even do IVF, we give progesterone.
That's good to know. Good to know. We're still on the topic of protocols. With patients with endometriosis or PCOS, I think you may have answered this question already in answering another. Do they need special protocols, or it's still the standard same protocol, even with these gynecological conditions?
So PCOS, now PMOS, is more than a gynecological condition. It's a endocrine condition. So it's a hormonal condition. And therefore, definitely, sometimes the hormones make a difference. Women with PCOS have a risk of this thing called hyperstimulation syndrome, which we really, really want to avoid. So we do modify both our dosage levels. We often modify the concept of putting an embryo back in fresh in women with PCOS. So there's a lot of things we modify with PCOS, PMOS. So we do individualize that a fair bit.
Okay.
In truth, while endometriosis is a really difficult gynecological condition for the woman who is suffering from endometriosis, from an IVF point of view, mostly it doesn't make heaps of difference. The stimulation is the same, the pickup is the same, and it's down the track again, the same as every other person. If they have recurrent failure, it's looking at the minutiae in that small percentage that has recurrent failure.
Superb. Thank you. So I want to shift a little bit to talking about the psychological aspect of going through IVF, because that's very much going to be part of the journey, particularly if you have a patient who has come to you because she's had reoccurrent IVF failures from another clinic. Let's talk about what to expect and delve in and be more honest with our listeners and our viewers. What should someone expect during a stimulation? Because there's that concept of ovarian hyperstimulation. What's normal during a stimulation cycle and what's not normal?
So right at the very start of stimulation, which if I'm going in period days, and so from maybe about day 3 for the first 5 days, most women feel almost nothing. They're not entirely sure anything's happening at all. Most clinics after that would probably start doing blood tests so that we're confident we're getting our response. And most clinics probably after around 7 to 8 days of stimulation would do an ultrasound. Now, it's interesting around that ultrasound, what we want to see, again, if we think that when the normal follicle, so one follicle gets to 20 millimeters, so 2 centimeters, and bursts open. So that's in a normal month. What we're now saying is I want 10 follicles, each at 2 centimeters, to be there. So everyone thinks and feels, and appropriately feels, that they're getting bloating and they're getting a bit swollen up. And oftentimes things like bowels change a tiny little bit with constipation. And that is really normal just by the fact that we've got 10 2-centimeter follicles all sitting in there.
Yes.
So that's pretty common, but most women will still go to work during that time because it's usually not too much to stop that. I mean, there's always possibilities, so I'm not saying always. Most women would probably still go to work during that time. You talk about so our reason for monitoring during the cycle is to make sure we don't overstimulate, because that's one of the few times that we can put health at risk. So the reason for monitoring, one of the reasons for monitoring, is to avoid that thing called hyperstimulation or overstimulate. So instead of 10 follicles, have 30 follicles. Women think that's good because they think they're going to get 30 eggs, but it's not good because it's a risk of being really sick.
Okay. In what way? What actually happens if you have too many follicles?
So hyperstimulation is something that interferes with the process so that you get a whole lot of swelling in the tummy, and the tummy fills up with fluid. There's pressure on so kidney function decreases. If it gets really enough, there gets fluid on the lungs. If it gets really enough, there's fluid around the heart. It's almost, we've got it almost under control now and ways of avoiding it. But back when I first started, it was really scary, and women would end up in intensive care with hyperstimulation. So it's one of the few things that is a risk, and it's definitely imperative on doctors to make sure it doesn't happen.
Awesome. Have you ever seen anyone die from ovarian hyperstimulation?
Touching lots of wood at this point, I'm very, very, very lucky that I've never had anything of that nature, but I definitely know of cases within Australia that has happened. Not in recent years. So it has happened, yes.
Yes. So we're more informed and we know more about doses and how drugs affect our bodies. Now, emotionally, is there a point in the cycle you see patients struggle the most? At which point of the cycle you reckon that people tend to struggle the most?
In a standard cycle, it's between embryo transfer and the pregnancy test, because you're sitting there and everything's just twirling around. And I feel really I feel really anxious for patients because I can understand what they're thinking. IVF is emotionally taxing. It can be expensive. So sometimes when we're looking at pickup, and if we haven't quite stimulated in the way we were wanting to, there's a decision sometimes, instead of going and picking up the eggs, of cancelling a cycle.
Ooh.
And that doesn't happen much. It's probably less than 5%. But that also is a very traumatic, emotional time that you've said, I think we can do better next time, but I really have. Wasted is the wrong word, but I've gone through the last couple of weeks with no outcome. And that's a very difficult time.
And sorry, can you come again with the criteria that would make you cancel the cycle?
Oh, I mean, lots of women have different criteria themselves. So it's mostly women themselves of, do we have enough follicles that you think it's worth it? I'm not going back to money, but I've only got exactly this amount of money, and I want to optimize everything as best I can. Oh, I don't think that's the right amount. So
Mm.
there's a few things like that sometimes you cancel a cycle, and that's quite traumatic and very emotionally taxing.
Okay. Yeah, that's fair enough. So what you're saying is it's not usually the doctors that cancel the cycles. It's usually women themselves based on the success of the egg collection.
It's even before going to egg collection. So
Okay.
if you're going to cancel, you go before. But it's a joint discussion. I mean, these things mostly are all a joint discussion and saying, okay, these are our potential outcomes. This is the options. What would you like to do?
Yeah, it's a patient-centered approach, we call it in general practice. I want to talk about something that even I, as a doctor, did not know existed until the conference about 2-3 weeks ago at the Gold Coast, which is low-cost IVF. Is it fair to say a lot of people in Australia don't know that these low-cost IVF clinics exist? Well, I, as a doctor myself, didn't know that they existed. So we're going to touch on it in this podcast. In plain, simple terms, what actually makes one IVF cycle cheaper than another?
Lots of things, really. I mean, it's the timing of things. So if I give examples between my clinic and a low-cost clinic, I'm there at 7 o'clock every morning and doing the scans myself so that patients don't interfere with work and they can go to work throughout. But in our low-cost clinic, the nurses scan under a protocol, so they don't see a doctor, which makes things cheaper. The scans are done on normal office hours, 9 to 10, because that makes that cheaper. It's absolutely protocolized, so there really is no individualization in low-cost clinics. I can only talk about the clinic that I know. A significant way of making things cheaper is, instead of having a anesthetic to put you to sleep, we use what you see the sportsman on TV, the green whistle, to use as the pain relief during the egg pickup. We don't do transfers on weekends because that involves costs and weekend stuff. So most of the cycles are freeze all and put the embryo back in the following month. And there's no variation. So there's no variations on the side, and there's no extra things that are all available in what I would call a standard clinic. So I think there's a standard clinic and there is a low-cost clinic. So if I gave one example, what we're doing more in the things that we've been talking about a bit today, which is recurrent implantation failure. One of the prime things that I would do with recurrent implantation failure is embryo biopsy and work out which embryo is chromosomally normal and only put a chromosomally normal embryo in. Now, that extra, so to speak, none of that is available in a low-cost clinic because, it's the whole process. It's low cost.
Okay. Another question that comes to mind because we addressed it earlier on in our conversation is egg freeze. So the women who go for egg freeze and decide they want to go ahead and be single mothers, for example, can they use a low-cost clinic?
Routinely, no. And again, everything surrounding donor is a lot of work. The registries, the counseling, the access to donor is a real significant amount of work. And so none of that fits into any way low-cost setups. I know there are some differing clinics in Australia that offer some lower cost egg freezing, not the donor stuff. That's a bit variable. The big thing about egg freezing mostly is egg freezing doesn't have a government or Medicare rebate in Australia. And therefore, that's the reason it doesn't fit into low cost. You still get the Medicare rebate. And so it's still, government gives a good rebate, but because egg freezing mostly doesn't get a Medicare rebate, it doesn't really fit.
Got you. So if we've got low-cost IVF clinics here in Australia, how come Australians or people who live in Australia actually go to other countries like Turkey or, other countries that are renowned for fertility tourism, let's say? Why are these people traveling to these countries as opposed to using our low-cost clinics?
They're going for what they can't get in Australia, which is donor eggs, donor things. So Australia is quite regulated with all of its donor process. And so, for instance, every donor has to be on a registry. It's a known process. People don't like that, so they'll go to countries. But so it's difficult to get donor eggs in Australia, more difficult than some of the other clinics. Australia, there's no, for want of a better word, social sex selection. So patients go overseas for that. So they certainly don't go overseas for low cost. That doesn't happen.
Okay. So in Australia, as I've had a patient of mine ask me, they cannot select the sex of their baby, even if they go for IVF. Right. Okay. All right.
In Queensland, it's now a jailable offence.
To the doctor?
Correct.
Wow. Wow. Okay. Okay. And so can people then ask you to try during their IVF cycle, they've had issues conceiving, they've waited so long to conceive, and they now come across Dr. Flynn, who knows what he's doing. How many embryos can you implant at any one time?
So in Australia today, it is pretty standard that it's a single embryo transfer, and that has made a massive difference to the complication rates of IVF, because the complications of IVF was basically prematurity and babies, multiple pregnancies, born early and in the neonatal intensive cares. So that's why IVF today has become so much safer with single embryo transfer. So the number of double embryo transfers in Australia, I would guess at less than 1%.
It's not an offense to transfer two embryos. No. Okay. And is there an age limit to egg freeze in Australia, to stimulating for ovarian stimulation to do an egg pickup? Is there an age limit?
Oh, good question. So there's no legal age limit, and therefore different clinics have their own options and opinions. My standard answer to this is that for a very, very long time, until not long ago, the oldest person in the world to get pregnant with their own eggs with IVF had a baby at 47. And therefore...
So sorry, how did she get pregnant?
With her own eggs. So every single person who is getting pregnant at 50, and all your movie stars are 100% donor eggs. So what you're saying is you're coming up and asking me to say no one in the world has got pregnant over 47, but you think you can do it. That's what it comes down to. That if so, for our limit and my limit round is for women using their own eggs, 46 around there. But that's even that success rate. The success rate of 46-year-old is very, very low, single digits.
Right. And so this other patient of 47, she went through an egg stimulation and an egg pickup, and it was her own egg that she went through IVF for.
I think that's the world record, or it was a couple of years ago. I could not quote that at this point.
Yes.
But in the literature, up until not all that long ago, that was a record.
Okay. So we've got the final two questions to ask you. So we talked about low cost versus the standard clinic. You used the word, I think it's the standard clinic you mentioned. What's the cost? Can you quote some numbers in Australian dollars?
In truth, I can't. This is in fact where there is the differences between clinics, because, and again, without hassling any clinic, but everyone always says it's bulk billed IVF, and then oftentimes you'll see a little thing on the side. Here's a fee for the egg pickup. Here's a clinic fee on the side, and so people market it as bulk bill, but it's never there. There is always a side fee. I would consider most of that is probably in the ballpark as a side fee, without being more specific, but that type of ballpark.
And in the standard clinic?
I think mostly the out-of-pocket would be something in the order of maybe about $6,000. Medicare in Australia, compared to most other countries in the world, is very, very generous, and there is no restrictions on Medicare. So I think we've talked in the UK, and I was listening just recently, to get a government-funded, i.e. Medicare cycle, you have to be under 35. They make sure that you have not had another child ever. If there's another child living in your house in the last year, you don't have access to it.
Yeah.
And so, and everything other than that is 100% private with no government funding. So
that's right.
Australian subsidy of fertility, and I'm certainly not being political because I don't like any governments, but Australian subsidy of fertility is amongst the best in the world.
And for people who do not live in Australia and who don't understand the term bulk bill just means the cost of any clinical, medical procedure or consultation that you're getting with a doctor that the government will pay for. So that's bulk bill. And when we say out of pocket, that means any monies that you'll have to pay on top of what the government is going to cover. The last question I'll ask, so now we're creating awareness about low cost IVF clinics. By the way, what's the name of the one that you work from?
Our specific low cost clinic is called the Fertility Centre. And there's fertility centres in Queensland and New South Wales and Victoria. So there's a number of the same type of centres in Australia.
Awesome. So it wasn't clear enough. Which patients should not waste their time coming to the low-cost fertility clinics?
So there's a lot of patients who do really well at the low-cost clinics. But patients with complex medical conditions, patients who've had recurrent failure around everywhere, are not going to get individualised care. they're going to get protocol care, and that's why the price is different. So I think they shouldn't come to a low-cost clinic. Patients who think they would benefit from a one-on-one. I mean, if I'm seeing patients at my standard clinic, scanning, and some patients really like that, but some people don't care if they see a different person each time. If it's some patients like really significant endometriosis where the egg retrieval is quite difficult because of the endometriosis that was stuck down, there is advantages of, in our clinic, not using a green whistle, but using an anesthetic where everyone is nice and relaxed. And endometriosis, the pelvis can be really quite painful and tender. And so there are some times, but it's usually, if someone comes to our low-cost clinic, I would usually say, I'm happy for you to come along, but it would be my advice that you would get better service at our other clinic. And as long as they know, then they've made their own decision. And we've told them at the start.
Superb. And probably women over 40, would you say? Because there isn't that opportunity of doing pre-implantation test, would you say?
So I am a believer that if I'm over 40, we should do pre-implantation genetic testing. It's costly and therefore it's money involved. So women who then come to the low-cost clinic trade that off by end up saying, I'm going to do more cycles, and say, well, I can afford doing more cycles because it's lower cost. There's no perfect opportunity, and I'm not hassling that theory, because everyone's different, and it's everyone does what's right for them in the end.
Yeah, and but those women can end up with children with chromosomal issues, because
it would then be the same as every woman who gets pregnant spontaneously over 40. So once a woman is pregnant with IVF, you treat them much the same as a pregnant woman. So you would still go and get what most women have, that NIPT test. You would still get an early ultrasound scan. So the treatment of early pregnancy hasn't changed. And if we became pregnant spontaneously at over 40 and we did that NIPT test and had a chromosomal abnormality, then there would be counseling through genetic counseling sessions, and you would be offered different options, of which, offered options what the patient wants.
Super. Dr. Flynn, thank you so much for being generous with your time. This has been such an eye-opener, even for me as a doctor. You've talked us through, the absolute roadmap. So I'm hoping that anybody listening to this podcast will know that here in Australia, we're very, very, very generous with our fertility treatment, and the government is superb at ensuring that the Australian population continues to grow by supporting, people on their fertility journeys, whereas in the UK they're a bit more strict. Thank you so much for your specialist input in front of everyone, and make you commit to coming back on the show. And this time we're going to talk about egg freezing in particular. Is that going to be okay?
Thank you very much. I'd love to.
Thank you, Dr. Flynn. Thanks, everyone. Thank you for listening to Conceived, the podcast. I hope that this episode has been helpful. We look forward to our next one. Until then, check out our other content on Hey Doc by Dr. Kady. I have lots and lots of fertility videos on there, lots of videos on women's health. And until then, we'll talk to you later. Bye. Thanks, Dr. Flynn. Bye-bye.